Welcome to the Explainer. Today, we are diving straight into a high-yield diagnostic playbook, and our goal is to equip you with completely foolproof cognitive frameworks for infectious diseases. We're going to map out the exact metabolic signatures, the radiographic signals, and the physical geometries you need to make those absolutely critical split-second decisions.
All right, let's kick things off with a high-stakes scenario where every single second counts. What is the exact tipping point that should stop you from immediately performing a lumbar puncture on a patient with suspected meningitis? Think about your default clinical reflex for a second. Is it to just send them straight to the CT scanner? Because honestly, that reflex might just be the most dangerous clinical blind spot in the entire hospital.
So here's our roadmap for today. We've got the executional pearl, the CSF audit, pneumonia vectors, and tick-borne speciation. Let's jump right in.
Starting off with Section 1, the executional pearl. We're tackling the most frequent execution gap you'll see on the boards and in the wards, the CT before LP decision matrix.
Listen, the absolute crucial point here is that you do not need a CT scan for everyone. You just don't. The definitive indications for a CT head prior to an LP are incredibly specific. We are talking about 5 things: a focal neurologic deficit, a new onset seizure, papilledema on your exam, an altered mental status with a Glasgow Coma Scale under 10, or a known immunocompromise. If you don't see any of those 5 specific things, the correct move is to go straight to the LP to maximize your diagnostic yield.
And this is exactly why we pause for imaging when those 5 criteria are met. You see that ring-enhancing lesion creating a severe mass effect? If you were to perform an LP right now and drop the spinal pressure below it, you are risking a fatal brain herniation. That right there is what those 5 rules are designed to catch.
Moving right along to Section 2, the CSF audit. Once you actually have the fluid, analyzing its metabolic signature is your key to cracking the 50-50 dilemma of meningitis.
Okay, I love this breakdown. Notice how the gluttonous bacterial pathogen behaves. It literally devours glucose, dragging those levels below 40 milligrams per deciliter, and it spikes neutrophils well over 1,000 to create this cloudy fluid. Now compare that to the passive guest of viral meningitis, where glucose stays pretty normal and lymphocytes just hover under 500. And you've got to watch out for the slow burner, fungal or TB meningitis. It eats glucose like a bacteria but triggers a lymphocytic response like a virus. It's tricky. Now, when you're analyzing that fluid, you really have to separate the signal from the noise. A positive gram stain or specific acid-fast microbial staining, that's a high signal finding. On the flip side, opening pressure is often just inflammatory noise, though keep in mind it does run exceptionally high in cryptococcal infections.
Let me be absolutely crystal clear about a potentially fatal execution gap. Never, ever delay the first dose of antibiotics just to wait for your LP or CT results. Acute bacterial meningitis is a massive, life-threatening emergency. You have to act decisively. So here is your definitive, step-by-step protocol. First up, draw those blood cultures immediately. Second, immediately push dexamethasone right alongside your broad-spectrum antibiotics, like IV vancomycin and ceftriaxone. And hey, throw in ampicillin if the patient is over 50. Now remember, the dexamethasone must precede or accompany the antibiotics. Why? To prevent hearing loss and severe neurological damage from the massive inflammatory response when those bacteria lyse. Only after all that do you proceed to the CT if indicated, followed by the LP. Okay, Section 3, pneumonia vectors. This is where we explore how extrapulmonary signals help us establish a diagnostic dividing line between pathogens.
The tipping point here is all about the clinical contrast. Typical pneumonia hits like a freight train, sudden high fever, productive rusty sputum. It's a dense, rapid assault. Atypical pneumonia, though, it's a slow burn. It's that classic walking prodrome with a nagging, non-productive cough and these patchy, diffuse interstitial markings on the X-ray. Radiographically, that sudden assault leaves a highly visible footprint. Take a look at this dense lobar consolidation up in the right upper lobe. That is the classic, absolutely unmistakable signature of a typical Streptococcus pneumoniae infection. But what if the X-ray is interstitial and patchy? Well, that's when you start hunting for systemic quirks to crack the case. Atypical pathogens leave really distinct clues outside the lungs. If you see a high fever paired with GI issues like diarrhea and low sodium, hyponatremia, that's Legionella screaming at you. If the patient has cold agglutinations causing autoimmune hemolytic anemia, you are almost certainly looking at mycoplasma. Time for another major inpatient pitfall. Please do not rely on a macrolide, like azithromycin, all by itself for a hospitalized patient. Because of rising resistance in streptococcus pneumonia, your treatment strategy has to be more robust. You need a respiratory quinolone like levofloxacin on its own, or a combination of a beta-lactam like ceftriaxone plus a macrolide.
And finally, Section 4, tick-borne speciation. We are going to map out the structural pathway here by looking very closely at rash geometry.
The absolute crucial tipping point here is the flow of the rash. Lyme features that early target shape that expands outward from the bite. Rocky Mountain spotted fever, on the other hand, is centripetal. It races inward from the wrists, ankles, palms, and soles right toward the trunk. And then you have ehrlichiosis. It's affectionately nicknamed syphilis, or MSF, because it mimics those severe systemic symptoms, crashing the white blood cells and platelets, but it totally hides out without producing a rash at all.
Let's wipe out one last clinical blind spot. Never withhold doxycycline for suspected Rocky Mountain spotted fever just because the patient is a kid under 8 years old. RMSF is a rapidly progressing, terrifying vascular emergency. The life-saving benefit of doxycycline absolutely, completely outweighs any theoretical or cosmetic risk of dental staining. It is your first-line treatment, period, regardless of the patient's age.
So, as we wrap up this explainer and you synthesize these metabolic signatures, X-ray patterns, and rash geometries into your daily practice, I want you to ask yourself a really hard question. When the pressure is on, are your clinical reflexes saving time, or are they costing lives? Master these frameworks so you never fall into the execution gap. Thanks so much for joining me. Keep learning, and I'll catch you in the next one.